Welcome to all of you. Welcome to our panelists. Tonight we're doing social determinants of health, and we have as our moderator Tanwir Kalimullah, who comes to us from the Harris County Public Health, our Public Health Department. And I want to speak a little bit about Tanwir's role in the background of this course when we started 2 years ago to put together the sessions and to choose moderators, and he was one of the folks who worked behind the scenes to help us pull this together and identify issues. And so we're really pleased that he's stepped up this time for the moderator's role. So, Tanwir, please.
Thank you. No applause? I'm just joking. Thank you, everybody, for coming here. First, I'd be remiss if I didn't say thank you to Dr. Linder, Dr. Garson, and the rest of the TMC Policy Institute. Texas Women's University, they are our partners, been this whole time very, very much with us, too. So thank you very much for everybody participating on this. The topic is the social determinants of health. And what I'm going to actually do is first, we're going to introduce the panelists, and then we have a few questions, then we'll get to some questions where I'm actually going to drill them and make them sweat. So anyway. First of all, we'll start from all the way to my left. Dr. Greeley, can you all hear me well? Okay. Dr. Greeley is the chief of the section of public health pediatrics at Texas Children's Hospital. And I just want to point out, can you all hear me? They were very deliberate about creating a section of public health and now section of public health and primary care at Texas Children's to address issues like the social determinants of health and ACEs, which we'll discuss later. He also serves on the Board of Directors of the Prevention of Child Abuse America, for which he also was the chair for many years. Right next to him is Dr. Keonta Moore. So she is at the Baker Institute. She is a fellow in child health policy. She is a dual threat. She's a lawyer and a physician. So be careful. And she does not know how to take a break. Anyway, that's a personal thing. Anyway, her research focuses on developing empirically informed policies to advance the health of children. I think a lot of her research that I'm aware of has dealt with a lot of the first 3 years, a lot of the issues related to trauma in that arena. And a lot of her work has dealt with a lot of research on the social terms of health in the schools, and I think with complete communities, for those of you who are familiar with that. Next to her is Robert. I didn't get the last name, Nanaki. No,
it's very difficult.
Did I get it right? Nanaki?
Inaki.
I almost had it. Okay. Robert Nanaki is the System Manager of Community Benefit Programs at Memorial Hermann. He oversees efforts that partner with governmental agencies, nonprofits, and civic leaders to develop population-based strategies that improve the health outcomes of Greater Houston communities. And he manages systems initiatives to eliminate food insecurity and mapping the needs and working with organizations to create effective interventions. Also, a lot of the efforts are not just around a specific area. He works in areas that try to really comprehensively work in communities like near Northside and those types of places to try to really get the community involved in advancing their own health. And to my left, this is my partner over here at Harris County Public Health, Stacey Lofton. She is a senior policy planner and also a health equity coordinator at Harris County Public Health in the Office of Policy and Planning. She's an attorney, but prior to coming to Harris County Public Health, she spent a lot of time, spent many years, several years at the CDC. After that, she also spent several years working as a practicing attorney before she came on to Harris County Public Health. Her expertise is in civil rights, health and racial equity, and her focus is health equity at Harris County Public Health, where she really does try to get the organization internally and our efforts externally to be really focusing on health equity. We'll get to that term in just a little bit. So just real quick before we start, I'd like to make sure we have this connection. How many people here are students? Great. Anybody in the clinical realm who's here? Nursing, physicians, pharmacists? Great. Good. Very good. Academics? Very good. All right. Good. Great audience. Okay, let's go. We are going to start with the questions. Okay. A couple of poll questions. So the first question, so for those of you who cannot see, if you go on your phone, you go to pollev.com/TMC. You go to that and it'll be the first question is, have you heard of the social determinants of health? We're just going to start off with something easy. Panelists, you're allowed to too if you want to. We'll give that a couple minutes. Just if you've heard of it. And also for people who are unaware, this is also live stream, so don't do anything embarrassing. They'll capture you on, and this will be posted on YouTube and in perpetuity. There are a lot of you not participating. Come on, everybody get on their phones. Do this. All right, very good. All right, so that means about 3/4 of you have heard of it at least. There's some of you who are somewhat familiar with the concept, and then there's actually some of you who have not heard of it, which is great. Okay. Okay, so the next question, which we'll get to, is okay. Choose the ones. Now, be honest about this. Choose the ones where you understand the link between these social determinants of health and health issues. So just click on the ones that you actually understand that there's the link, how that actually affects health. And you can pick more than one. And panelists, if you don't mind looking at the results as well as we're coming in to see if there's anything that surprises you or makes sense. Okay. For those of you who can't see, for the most part, it seems like housing, people understand the relationship between health and housing, security and quality, education, food insecurity, and employment. And then I would say probably the next rung is intimate partner violence and transportation. So those are, seems I think run something fairly square with everything that we know. And then we have, to a lesser degree, things like stray neighborhood animals, absent or broken down sidewalks and parks, and then in the same vein, immigration and incarceration. So okay, that makes any comments on that or about what you thought, panelists? Same? Okay, great.
Right. I don't know if we'll get to this later,
Yeah.
but and maybe this is just maybe in defense of the two lowly ones. But a project we work on, I think when I first started with some of this work, we are, so I'm in Memorial Hermann again. And so a project we're working on, we're trying to connect the community and give people the opportunity to advocate for their own health and help think about them outside the clinical environment, how they could maybe think about their health just outside the interventions we'll talk about. And so just advancing that work and trying to connect that community, we found something as simple as in trying to activate a park down the street from a school, there was a broken sidewalk. And people didn't go outside and wouldn't go be with their neighbors. And one of the reasons they wouldn't do it also is there's a massive stray dog, bulldog problem. People love having bulldogs, but didn't love keeping the bulldogs. And so just roving packs of dogs were in the streets. So kids wouldn't go out, they wouldn't get active, they'd stay inside of their homes. Parents were working, so who knows what the kids were eating or what the kids were doing. And so no one was going to this amazing park. And so a lot of my work disproportionately has been trying to build out this sidewalk, working with construction companies, working with all of these other council members and things like that for like 6 months and trying to build a sidewalk. So we would never have imagined we would start here. But I was hoping while I was talking that number for sidewalks would tick up.
All right, what we're going to do, actually, thank you, that's actually a great segue. So what we're going to do is we're going to lay a little bit of a foundation, and then we're going to open up to audience. Feel free at any point, once we lay the foundation, to ask questions. If you have any comments that don't go on too long. But comments and questions, please feel free. This should be a discussion. We plan to have that here as well. So we're going to start off with Dr. Greeley. If you don't mind just giving us a nice academic definition of the social determinants of health.
Okay, so good evening, everybody. It's wonderful to be here. This is a very sophisticated audience, so clearly many people know some of the context. And so for those who are unfamiliar, the social determinants of health are what I tend to sort of conceive of as the social drivers of health, and we'll hopefully get to that in a second, are cultural, economic, social factors that influence or affect the health and health outcome of either a person or a population. That's sort of broadly a conceptual framework of it. And that includes a lot of the things that are listed behind specific focusing on a person or a patient, like food, violence, education, or larger factors such as employment, policy, justice. And the way I conceive of how these all live together is in 2008, the World Health Organization published a report from their Commission on Social Determinants of Health, chaired by Michael Marmot, who is my academic crush. It's sort of something I need to pass on. Everything he writes, I read. And their report, Closing the Gap in a Generation, framed it really, there were two main focus areas. Their whole report was subtitled, Why Treat Somebody and Send Them Home to the Conditions That Made Them Sick? And it was this framework of daily conditions of living, sanitation, food, security, as well as access to resources, power, inequality, and influence within your environment. And it was those two areas. It wasn't just, does this person have food, but what are the larger factors at play? And it wasn't just, what are the larger factors at play, but does that person have food? And so they struck this balance that in conceiving of social determinants of health, that it really should embrace both of those processes or thinking as you want to address a specific health need.
Great, thank you. So on that, and I'm going to ask everybody if there's anything you want to add to that, but mixed with that question, there's another term called population health. And if you're in healthcare and you're in public health, the definitions are not the same. And do you feel, panelists here, and also if you have anything to add to the definition or to modify, do you feel as the social determinants of health has evolved over time, if there is a difference in how that term is being defined, or I guess all the different interventions or how it's being treated? Anybody feel free to.
So I'll take a stab at that question. I think it depends on who you ask. It should not be different. But if you're looking at population health management, then your population in that respect includes the patients, right? The hospital population, which usually are the patients. But with some institutions, it includes a broader perspective or a broader population to include the community and not only that hospital's patient population.
Anybody else?
I just wanted to add, I'm not a public health expert, and so I'll defer regarding the definition of population health, but I did want to add just for the social determinants of health. So Robert Wood Johnson recently held their Culture of Health conference here, and so I was a part of planning that. And looking at all of the social determinants of health, there were over 65 social determinants of health. Right, so we're talking about basically, and I'm glad Dr. Greeley mentioned this daily living, right? So almost every aspect of our life, of our childhood, of how we interacted with our parents, the schools that we went to, every aspect of our life really could be a social determinant of health. And so it's very broad, social determinants of health.
Okay, that's true. There are a lot of different models. And just to close off this part right here, we do hear the term adverse childhood experiences, ACEs, and is there a relationship? Are they synonymous, or how would you describe, if anybody wants to, maybe, the people on the end have much more in that area, so I'll give it to y'all. But if you don't mind, just describing the relationship between the two.
So to give some background, what Tanwir is mentioning is the concept of childhood adversity. And really, it was first popularized in the mid-90s by some work funded by the CDC a study called the Adverse Childhood Experiences Study, where Kaiser Permanente in Southern California had a cohort of almost 20,000 people, mostly adults, mostly retirees in Southern California, and said, tell me about your childhood, and asked very specific childhood adversities. Did your parent die? Were you abused? Was there mental illness? Was there drug and alcohol? Was there an incarceration? A series of 9 or 10 very specific adversities, and then linked their simple score of the worse your childhood was, or you recalled your childhood was, the worse a whole series of health indicators were, from early mortality to mental health to employment. And so this idea was that the adversity or the challenges that you grew up in your childhood translate over your life course, and the worse it was, the worse the impact of you over your life course. And the data has been repeated in many, many locations, not just in the United States, but globally. And that relationship between the challenges of your childhood and the impact on your life has been really, I think, really quite clear. So there is a clear relationship. If you grow up in a household where there's profound violence and poverty, and all of these things tend to are collinear for the nerds out there that are kind of live together and cluster together. These things tend to aggregate over the course of a person. And I, as a pediatrician, really only think about children. And once you get sort of 18, 21, I tend to have very little interest in you. And so there is a clear relationship that the social determinants of health can broadly be framed as risks or as supportive factors. And so you can have, as the CDC would frame, a safe, secure, nurturing relationship as a household, or you can have a violent, hostile household. And both of those are social determinants. One is a risk factor and one is a supportive or growth factor.
Great, thank you very much. Okay, and the last of the foundational questions. Okay, many times when we hear social determinants of health, we also hear health equity. Sometimes maybe synonymously with that's incorrect or correct. Stacy, would you mind actually explaining that relationship, or what exactly how do those two terms go together?
So those 65 or so determinants of health often lend to opportunities, and health equity is about ensuring that everyone has a fair opportunity to achieve health and well-being. And so the opportunities that we speak of are those facilitators to health, those factors that protect health instead of increasing the risk for the community and individuals.
And just to kind of help, is there any like an example that you can give, maybe as far as like maybe something structural or something that occurs that you can kind of point to kind of help maybe give something to latch on to, I guess?
So for instance, I think one thing about social determinants of health that we need to understand is that they're, as Dr. Greeley kind of explained, they're interrelated and interconnected, right? And so it occurs that social determinants of health influences individuals and communities across the lifespan. And that compound of determinants essentially kind of determine the level of opportunity that an individual community will have. So if an individual or a community is consistently marginalized, if they're consistently overlooked or discriminated against in terms of the distribution of resources that we consider to be social determinants, right? Transportation, housing. If individuals and communities do not receive those resources on a continuous basis, then you'll find increased inequities within that community or facing that individual.
Anybody else like to add anything?
I'd like to. So I absolutely agree with that, and I just want to highlight maybe a nuance that part of it is also about ensuring that everyone has the same capacity to take advantage of opportunities. So one might say, well, an intervention actually, I was just reading a paper that just came out in Health Services Research, and it showed that the neighborhood factors could actually predict whether or not antidepressant therapy was effective for patients with depression. So basically, all of the patients don't have the equal capacity or opportunity to get well because of the neighborhood that they come from, right? And so that's an inequity that's rooted in a place or in a zip code. And so when we talk about equity, it's not just ensuring that everybody has access to health insurance, or everybody has access to seeing a doctor, or everybody has access to going to school, but it's about, when you give me access, do I have the same capacity as everyone else to be able to get the same benefit from those opportunities?
I could add something to it. And so, even obviously, I can agree with both of you. And so, I think one of the maybe more salient examples that people can think about is Harvey. A lot of people there's a climatological gentrification, how people have the ability to move out of their places because they're experiencing some of these maladies. You go to work and you don't have to think about the fact that your car got flooded, but depending on your social situation, your car got flooded, you got the ability to buy another car the next day, right? Some people are still dealing with the after effects of Harvey, and they're having to deal with those stressors that compound all of these other problems. And then if you think about like where people live, especially in Houston, how a lot of the gentrification is pushing out people to the outskirts of Houston, especially with that ITC explosion. A lot of those people are now dealing with that as their environment, right? Some of us get to drive to other places. I get to go to Sugar Land. We have decent air over there, right? We're not dealing with the after effects of that. But if you think about it, all of these things will cascade, and some of these people end up, from Memorial Hermann, they'll end up in our facilities, and they'll present as something that looks like it's something completely unrelated. And then, the conversation we're trying to have with clinicians is factoring all these things, asking these questions, so that we're able to talk about the root cause rather than just attacking the currently presenting thing.
Right. And just to add to the Deer Park thing, so just to maybe, and you can correct me if I'm wrong, as already described here, you had this structural level. I'm not a panelist, but I'm just kind of adding more in my public health role. You had the structural issues, which are kind of the equity issues. So you ask, why are all those people living out in East Harris County, where there's hardly any health access, buy all these plans, where obviously you're going to need all these types of things. So why are all those people, that's a question that is rooted in health equity. Why did that happen? All those people who are living there, they all happen to be, or not all, but a great proportion of them happen to be lower income, and there's a certain level of minority population out there too. So these are things that are, as we're trying to integrate all these things into the healthcare and everything else, that we want people to start thinking about as we're approaching health. Okay, great, thank you. And if anybody has any questions or comments, please feel free to ask. Okay, great, thanks. But feel anytime, interrupt. All right, so we already kind of laid the groundwork. So what I want, just if you don't mind briefly, but just to kind of give, because a lot of this stuff is conceptual at this point. There were some actually good practical applications, but to kind of help everybody in the audience and people, whether they're live streaming or here, to understand like what are the things that we're doing about this. If you don't mind, give me just a few minutes or a couple of examples of things that y'all are working on to kind of show like how, whether you're in academia, if you're in a hospital, if you're public health, what are things that you may be working on that are something that I can actually do as a clinician, as a community health organization, or whatever else? We'll start, Dr. Robert.
Not a doctor. So some of the things we're doing, like I mentioned, trying to advocate for that those points. The work we're doing around the sidewalks, we're also beautifying them, bringing in artisans so the community can have more love for their neighborhood, so they don't feel like they have to leave. Some of the work that we're doing in other parts, so we're partnering with, there are schools that have areas that don't have, maybe they have access to grocery stores, but they don't have full access or the ability to access those things. So in our hospitals, we're tracking who's food insecure. In our clinics, we're tracking people that are food insecure. At some of our MGs, so typically you look at those people, they have the ability to have insurance. So we think if you're going to a clinic, you should be at some level secure. But we're partnering with the food bank to give prescriptions for them to be able to go to the pantries or other facilities, so they can address some of that food insecurity, but so they can also have a conversation about the kind of foods they should be eating. We partner with different communities on, a lot of our emphasis is trying to figure out what the community wants rather than just kind of telling them. We have knowledge, we have our interests, but we want to be able to understand, okay, what is actually affecting this community? How can we better partner with this community to figure it out? So we're going into a few different areas of the city right now and having those conversations, whether it's a church, whether it's a school, but just figuring out what is necessary to be able to come to something that actually helps them so they can think that we're not, parachuting down. And then, sorry, talking a little longer, but I want to say one more thing about population health and social determinants. So, Memorial Hermann, our goal is to attack it at a few different levels. Being able to say, population health, we have an ACO that we bring in people through our insurance provider, and they give us lives to take care of, manage. And so we're coordinating care and thinking about those things in our hospitals. We're asking about their food insecurity and their giving the prescriptions to go in the park and exercise so we can manage down the costs. From the clinical perspective, we're trying to partner, just get a good ROI, a proof of concept on both sides, so we can get a better sense of how to actually attack this when maybe someone will reimburse us for some of this work later on.
Dr. Greeley, would you mind mentioning some of the things that maybe are going on in your ACEs groups or other things you're working on?
So as a Children's Hospital and Department of Pediatrics, our focus is clearly on children. And we in our group focus a lot on childhood adversities. And an example of how we've tried to be thoughtful and thinking about this is we finished up just a few months ago the first round of a project looking at the impact of parental incarceration on children. And it was a wonderful collaboration with a number of partners in the TMC as well as with the Sheriff's Office, and we're able to collect data and identify that every year 92,000 children have a parent that spends at least one night, actually an average of 24 nights, in the Harris County Jail. 7% of every child in Harris County has a parent that spends an average of 24 nights in Harris County on Baker Street right downtown there. And we've identified this by interviewing the kids, the inmates, and the kids' caregivers. What are their needs? What is it that incarceration as an adversity has overlaid onto this child's life? And the partners and the Sheriff's Office have been absolutely phenomenal in thinking through. Now, starting over the past few weeks, the Harris County Jail is becoming a family-friendly jail. And so this idea of identifying adversities, looking at them systematically, and then implementing changes to hopefully have a lifelong impact on the child. At some juncture, we may get into things like why the parent was in the jail in the first place, bail bonds and inequality with who gets arrested and who can make bail. But we're starting with if the kid is going to be affected by the incarceration, how do we make that less onerous to the child? And that was really a phenomenal project, which, by the way, was supported by the TMC Health Policy Institute. And it was a project that has now garnered 2 subsequent grants to work with the National Institutes of Corrections to develop collaborations for this population between nonprofits and the school system and the jail. And so the idea was to look at specific adversities. What do we know about them? How do we then gather a team around who can affect that adversity and start piloting changes or piloting policies to ultimately then look at how do we then impact the lives of those kids. And that's an example. I might have a few others, but I don't want to steal the time.
If like that, we can come
Pass
back to
the
that.
baton.
No, that's good. Stacey.
So at Harris County Public Health, we have an inside-out approach to addressing health equity and social determinants of health. And so our inside approach is doing that work to understand why these inequities exist, why these social factors that we're discussing are distributed in the way that they are. And a lot of that is related to what we discussed earlier in terms of those structures, right? Structural racism, ageism, all of the isms that you can think of, we discuss internally, and how that impacts the communities that we serve, how that leads to a lot of the health inequities that we're trying to address, that we're working to address. And so that's our inside approach. We have a Health Equity 101 course, which discusses the basics related to health equity and social determinants of health, how they relate. And then we have a 10-week long health equity learning collaborative course, which is really that deep dive into those structural and social determinants of health and how they influence health equity. And then our outside approach really is taking what we've discussed internally and then sharing that with the community, right? Helping the community to understand historically why their community, why place matters, why the inequities exist within their community, right? And then change that story to change the narrative to reflect the culture and celebrate the culture and the strengths of that community. And we do that through various programs such as Healthy Living Matters, where we work with communities to kind of design safe routes to schools and implement policies that support healthy communities. Focusing on determinants of health, we work with schools in different sectors related to healthy living with the goal of reducing childhood obesity and obesity inequities, if you will. And then we have, I'll share one other initiative, which is the Community Health Impact Plan, which is a plan to address a myriad of issues, maternal and child health, access to health and social resources, early childhood education. I'm trying to think of some. So there are a few other priorities. And those, and that plan is a coordinated initiative to further equity and make sure that we address the determinants of health in a coordinated fashion.
And then, so I don't practice medicine. Most of my work is really trying to bridge the gap between community residents, regular, everyday people, and policymakers. And so one of my projects involved, so many of you are familiar with Third Ward. It's actually not too far from here. It's right across McGregor. And Third Ward is a really interesting community. It's historically African American, and they have many of the factors that we've talked about somewhat today of having a variety of social determinants of health. For instance, about half of the population makes less than $10,000 a year on the northern part of Third Ward. The southern part of Third Ward, as you drive down McGregor, it's much more affluent. But that northern part, going towards 45, the residents there make less than $10,000 a year. And so, so my work is really about how do we translate data into action or policy. And so this work was funded by the Houston Endowment and in collaboration with the community members and a community effort to neighborhood revitalization, right, to improve the neighborhood. And so part of that is not, I think for me, what are all of the deficits, right? So we could probably sit here for days, right, talking about challenges and deficits of being low income. But that doesn't necessarily solve the problem unless someone in this room has a solution for poverty. And so how do we figure out, ways to elevate communities and change the narrative? And so one of those ways is through my research, something called collective efficacy. And the resilience, people have been talking about resilience, and so collective efficacy is related to resilience in that it is a factor of me not only feeling good about my neighbor, so I like Robert, he sits next to me, maybe I may say hi to him when I check my mail, but more than that, I actually believe that if something bad happened to me or my children, Robert would intervene on my behalf. And that's really what collective efficacy is. And so in Third Ward, when we surveyed the neighborhood, we found that they have high collective efficacy. So even despite some of these factors, actually their health outcomes are actually better than what we expected. And so how do we, in this conversation around social determinants, which is really almost a deficit model, how do we also make sure that we include the assets and the qualities about neighborhoods and about folks that we can leverage to actually improve health? And so that's my work.
Anybody have any questions? Comments? I used to be a teacher. I'll call on you if you don't ask. Somebody's got. Okay. After hearing all the things that you've heard thus far, especially if you're, I mean, even if you're not, but especially if you're a clinician across the board, how many feel a little overwhelmed by some of the prospect of having to deal with issues of housing or these types? Anybody, by a show of hands? Y'all are a strong group. Yes, okay.
Yes, sir.
Yes, no, yes, ma'am.
You can call me sir.
No.
Robert, so
Yes,
how
sir.
does the hospital pick the neighborhoods that they go into for the parks and, working with the community around the parks that they have in their neighborhoods?
Yeah, so for some of the neighbors, so one of the neighbors that we're focusing on the sidewalk piece, we have a school-based clinic at one of them, and we noticed a lot of instances of acanthosis necrocan. It has something that kind of is one of the factors that might lend to someone maybe getting diabetes. And so we thought that would be a great place to have the intervention to get people more active so they can, defray that. And another one is kind of these areas that have maybe we're seeing people come into some of our clinics. Maybe we've worked there or have another partner that asks us to come in. Different things like that. I mean, we have school-based clinics around the city, so we're getting in data. We're asking the question about food insecurity across the system. A lot of people go to Memorial Hermann's, so we have a lot of data to be able to map out stuff and see. So it kind of depends on a variety of factors. But yeah, that's kind of.
Oh, I'm sorry.
I wonder if anybody up there has learned whatever happened. There used to be a program years ago when I would be riding the bus home. I'd ride with, they were mostly men, who would go into jail on Friday night and come out on Sunday night because they committed some type of crime, maybe hot check writing or something, but they were the breadwinners. And so when you're in jail, you're not at work, and this program would allow them to go in over the weekend, but they could still go to work Monday through Friday. And I thought, wow, what a great program, because they still get to be in the home with the family, and they're still earning money. And I wonder if you all know, whatever happened to that? Can we start that again? Because I thought it was excellent to keep the man attached to the family, and he's bringing in income, which then you can buy the groceries and what have you for the family, and not have that income missing as a result.
They're too young to remember that program.
So there was actually, as part of our project looking at the impact of parental incarceration, we added a couple of questions to the Harris County intake form and asked questions about who was the person coming in and what kids were at home, what zip code did they live in, what school did they go to. And 67% of all inmates were the sole or primary breadwinner of that household. And the average number of children was 3. And prior to us identifying this, there was no systematic way to know how many kids were being impacted by the incarceration. Now, 80% were the fathers, and the fathers, if they were incarcerated, the kid 70, 80% of the time lived with the mother. But if the mother was incarcerated, it was less than 30% that they lived with their biological father. They lived with an aunt, a grandmother, a cousin. And so the impact of incarceration was not equal. And the idea that the person spending the night in jail could not get their job, could lose their car, could then, one of the biggest issues was if they're in longer than a month, how do they sign up for things like Medicaid, get enrolled in school? Because if they are the legal guardian and no one can get them to sign a piece of paper, that child loses. So anyway, that was sort of the idea. And it gets to the idea that the system could be hostile or it could be more friendly. And our goal is to think of how do we make it more friendly.
Is another hand? Yeah, wait. Let's get a microphone to you real quick.
Thank you. I just had a question for Dr. Moore, just kind of in relation, again, to the social determinants of health in relation to kind of improving neighborhoods. Where do you find that fine line between improving circumstances and kind of in a neighborhood and keeping that for the people who live there and gentrification?
That is an excellent question. Somebody must have fed you that. So I'm actually glad that you raised that question. We had maybe a year ago or so, maybe it's been longer, we had an event actually at the Baker Institute around gentrification and neighborhood revitalization. And a woman named Vicki Booth, who is a senior evaluator at the CDC, came down. And on the panel, she told this story about how public health, the field, the CDC, they got, some money allocated to them for neighborhood revitalization to change neighborhoods, because we know that one of the social determinants of health, right, is the neighborhood that you come from. And so they wanted, as good public health officials, wanted to change that circumstance. And so they invested a ton of money in a couple of neighborhoods around the country, and they and she, and actually I think the video is still in the Baker Institute. So if any of you want to listen to her, I'm not doing her justice, but she talked about how proud they were and how they did an evaluation, several years later, and people's careers were built on this, and they wrote lots of papers on this about how they changed health outcomes because they revitalized the neighborhood, and then they did a 10-year review, and they looked back, and they actually realized that the folks that they had followed up with a couple of years later were actually different than the folks who lived there before their intervention. And so they had inadvertently caused gentrification and displaced all of the people that they had originally meant to help. And so it's a very real issue of how do we improve neighborhood conditions, right? But how do we ensure that the people who we intend to receive the benefit actually receive the benefit? And so that's part of the work that's happening in Third Ward. The funders, and along with the county and the city, the Mayor's Complete Community, is trying to develop, strategies about how do we secure the land, right? Because now it's, desirable for developers, while we are doing all these other efforts to improve the neighborhood. And so thank you for that question, because it's a real issue, and it's one that often people are not mindful of when they go to fix a situation, right? It's these unintended consequences of our actions.
You want something to add? Okay, no, I thought you were looking at me. Just actually to make it, I'm going to add a little more to that. Just to make it a little more real, I went to some event one evening, and there was I think a small organization that kind of works in Third Ward called City, SIDI, and they were showing a video of this 70-year-old or 80-year-old woman living in her house for like decades, and her husband had passed away, but because of gentrification, she had to move out. But she is she's older, she's fit to a certain degree, but she hadn't even started looking for a house, but she was going to have to be leaving her house within a few weeks. What was going to happen to her? Luckily, that organization just happened upon her, and they found her a new home, but that's her home for like decades. And only happened to because of the conditions. Now, I think the tough balance is there's some dilapidated issues that you don't want to bring there, but how do you keep the people there? Like you're talking about the policies. I mean, the sad thing was, who knows if there's some type of connection with, that she was in her house, and they found her house, thank God. But then, she passed away just not that long thereafter that. If there was, these are people's homes, they've been there for decades. So just to make it a little more real about, yes, please, go ahead.
Yeah, so that's a great question, and if anyone has the answer, please tell me. That's something we constantly think about with any of the work that we do, and that's why one of the main parts of any kind of intervention that we do at Memorial Hermann is partnering with the community, because you can build up the structures, we can beautify that park, we can augment that sidewalk, but just as easily as that 70-year-old woman, that can be pushed out, not being able to keep up with the taxes. But if we partner with a community development corporation and they buy up houses, we can talk with the civic association and work with them on how to be advocates, so they can go and talk to their council member or pick the mayor and things like that. And when you empower those people and the organizations that make up that neighborhood, rather than just the built environment around that neighborhood, then you enable people to be able to fight against gentrification. Again, I have no idea what the solution is to gentrification, but you can maybe slow it down. If I have $1 million and your house costs $80,000, you might sell it to that person, right? But maybe you can slow it down a little bit so the neighborhood can keep some better outcomes.
Right, and I think there are a number of approaches that you can take to protect against gentrification. So working with the community, understanding the narrative of the community, and then making sure that health and well-being is part of all policies. That's where the concept of health in all policies really comes into play, because when you're thinking about community development, you bring engineers, architects, urban planners, public health folks, community members to the table, and the focus should be the health and well-being of the community, right? And so when you're developing policies to build a community, rebuild a community, that should be taken into account in terms of the policies that support the development of homes, schools, all of the entities within a community.
I'll just add one other thing. For those of you who are interested on the health impacts of gentrification, and gentrification as defined as being forcibly displaced, there's a book by Mindy Fullilove. She's a psychiatrist, and it's called Root Shock. There's not a ton of literature. We hope to be able to contribute to the literature around the effects of displacement. But even in the Moving to Opportunity, where the federal government had funded folks, a randomized control trial to move folks to better neighborhoods, they found that for the African American boys, their health was worse, or mental health was worse. And so I think it's a complex issue, and so being able to understand this, I think, is critical. But it's Root Shock by Mindy Fullilove.
Thank you very much.
She was my professor.
Mr. Nick Moderino, yes, please. Oh, we have. Okay.
You asked the question earlier about the social determinants' impact on the delivery of care and the outcomes of such. Robert, you suggested Memorial Hermann. They've done foundational work around that, but Tanwir, you're chairing, along with the American Heart Association, a community-wide effort to really address sharing that information when care is being delivered so it can have the best outcome. Perhaps you should comment on that further.
Thank you very much. That was a good setup. That was a good volleyball setup. Let's see if I can spike it. Anyway, so just shortly, there is a coalition that's been in existence, but it's been renamed, and we, Harris County Public Health and American Heart Association, inherited co-leading or co-facilitating. It is called the Greater Houston Coalition on the Social Determinants of Health. So it's a long name, and I apologize for that, but we didn't choose it. Anyway, so there are a couple of pieces to it, but the primary piece, what's been driving the last couple of years, is as we're looking at the social determinants of health, and we're trying to get the healthcare sector to migrate, because we have a lot of great people here and a lot of great people in the audience, but I think the truth is, at this point, healthcare is still much better than it was a few years ago, but there's still a long ways to go to integrate all these types of the investigation of the social determinants of health and implementing it within the healthcare sector. So one of the ideas that started this coalition was, how can we make screening for the social determinants of health, starting with food insecurity right now, just like a vital sign. Just like you take your blood pressure, just like you take your weight, you screen for social determinants, you screen for food insecurity. That way, at least it's in the medical records. And as if you go from Legacy Community Health, you go to Memorial Hermann, you go to Texas Children's, wherever that patient goes, it's embedded in the medical records that travels through the Greater Houston Health Connect, which is the local health information exchange. So that way a provider understands that, oh, this person is food insecure, and they can incorporate that at the very least into their advice and treatment. So that's the first part of it. And then another part of it is, if we can actually take some of that data, and de-identified, of course, and then map that out to kind of see because we have a lot of these issues, we know it's there, but where is all this happening? Where are the concentrations of this? We have some great work going by Dr. Linder, which is soon to come out, the Health of Houston, so that's your free advertisement. But where are some of these things that may be co-positioned with some of the health issues? And that's the intent right now of the coalition at this point going forward, so thank you for that.
Can I add a little more? Oh, sorry.
Oh, yeah, please go.
One of the things we're doing, kind of piggybacking off of your volley, I was going to try to. In our clinics, in our hospitals, inpatient setting, across all Memorial Hermann, when a person is identified as food insecure, one of the things we're trying to do is affect that clinical conversation with the doctor so you identify this person as food insecure. I shouldn't give you a medication that requires a full stomach because you're not going to adhere to and you'll be back. And a lot of the, kind of touched on this a little bit earlier, but a lot of I've been going around the system having these conversations with our doctors, with our nurses, with our MAs. And people are hesitant to engage in that point because they feel like, I'm going to get this conversation back, but I'm not giving you a sandwich or anything like that. So why am I engaging in any of that? And so it's a lot of just getting people comfortable with this piece. So, the effort of having someone aware that if someone is identified as food insecure, they're going to keep coming back to me. So one, there's that piece. I want to give this person good care, so I need to understand all parts of his life is another thing. And I think, I can run around telling you about the conversations I've learned, and you all can keep saying that stuff. But I think a lot of this, we're only going to be able to do so much until we have a full engagement, and I know there are doctors in here, with clinicians in that community, because we're going around the community talking to them about things, but even if it's 20, 10%, whatever you want to say is about the impact of clinical intervention in your social determinants, a lot of it's what's happening inside of that area, examination room, when you're talking with your doctor and he's telling you about how you can take care of yourself. And so I just wanted to put that out there. That's what we're trying to do at Memorial Hermann, and the hope is that happens everywhere across the system.
You had to look. I didn't look at it.
Yeah. So I'm going to confess skepticism because I don't think it's up to the providers because my wife tells me it's not, and she's a pediatrician. Because the way the system is set up, that's not the skill of the provider to do that. That's my first point. The second point is I also have skepticism because the reason they're food insecure isn't because they don't have a sandwich. It's because they don't have a job, they don't have transportation, they don't know what to do if they buy kale. They don't have that. And so getting a food pantry could be helpful for a subgroup who the knowledge of where the pantry is the problem. But I'm still somewhat skeptical that here's a list of pantries will lower a community's rate of food insecurity. And I'd love to have someone show me data, prove me wrong, argue and stuff. I think that's the challenge, is that we've placed it on the provider. And I know if that person's food insecure, I may be able to adjust medications slightly, but they're gonna leave probably still food insecure. And I just sort of wonder that if that's valuable, but if that's the only way that we deal with food insecurity, I'm concerned that it will be dissatisfying.
I actually have similar concerns. So everything he said, and so I think it's important for clinicians to understand everything that we're talking about today, because it does affect treatment decisions, and it should affect treatment decisions. I think I'm also concerned this idea of taking these social circumstances and now putting it in a chart that then follows patients, that it's going to reinforce implicit bias, which is already killing Black women at a rate of 3 to 4 times likely, 3 times more likely than white women for maternal mortality.
Could you explain the term for people who are not familiar with
implicit
implicit bias? Yeah.
Oh, define implicit
Implied,
bias.
yes.
Oh,
Define
yes.
implicit bias. Yeah.
So implicit bias is basically the exact opposite of overt bias or conscious bias. So it's a subconscious perception about populations of people that you're not aware of. And all of us actually have implicit bias. As human beings, we've been exposed to media, we've had various life circumstances, we've had a variety of narratives that have entered into our psyche. And most of the time, those narratives are negative when it comes to people of color. And so what happens is, if I already in my subconscious have this bias that I don't know about and think I treat everybody the same. But the literature is showing that physicians are just as biased as everybody else, right? So it turns out that doctors are people, believe it or not, right? And so these people, even when they're doing their job, these biases influence how they treat one patient versus the next. What treatment options they give, what education counseling they give. And so now you've taken this maybe subconscious thing that was hanging in the background, and now you've presented this patient where now I have all this information around how bad this person's life is, right? And so who's to say that won't reinforce now or justify for myself the reason why I think about these people this way? And there's really no research right now on how incorporating social determinants of health, screening and clinical care is actually influencing these treatment decisions and implicit bias for physicians and outcomes for patients. And so I do have deep concerns about this moving so quickly without understanding the impact of it on people's lives, right? So the stroke literature, cardiology, right? So it's not just OB-GYNs, right, or that are implicitly biased and creating this disparity in rates of death, right? It's other physicians, it's all physicians. We all have some level of bias. And so now you give me all this ammunition. I'm just wondering what that really looks like in the real world for patients.
I mean, the hope isn't that we are aiming for high quality outcomes for everyone, period, right? So that's our first aim. I would tell you, if we don't have this indicator, then I think we lose out on a lot of ability to do anything. Memorial Hermann, we're trying to do inside and outside, right? So we have people who are coming into our facilities. We're trying to look at the whole patient. We have communities that people will never be patients for us. And so we're doing these programs to address the problem on all sides. So to your point, Dr. Greer, we're not just looking at one aspect of it. But I think you have these amazingly influential people who are interacting with people on their health. And people look at doctors as these experts. And so whatever, there's so many studies that show just by doctors giving an extra piece of advice on, vegetables or medicine or exercise, the disproportionate impact they have on people's outcomes. So our approach is to incorporate the doctors in the conversation. No, it's not a be-all, end-all. I will say your point about implicit bias, I think it's completely valid. I don't have the answer to that. I think that implicit bias permeates everything from the way the person dresses when they're walking into the examination room. Why, if I have a gunshot wound as opposed to someone who just has, gout or whatever else. So I think there's a lot that there's a lot of work to do, just like social determinants. A lot of it's poverty. We can't fix poverty. That doesn't mean we shouldn't do anything. So I think our hope is to start working, see what the problem is, and keep moving. Because before people didn't use antiseptics. No one cleaned their scalpels before they used people. People use leeches. But I think as we go on, people get better at clinical care, and I think our hope is to be able to do that.
Yeah, so I would agree. I think there are clear data, for example, that the impact of a physician counseling a patient on smoking, there is an impact on smoking rates. It's not tremendous, but it does have an impact. There is a value, but smoking rates didn't go down because doctors did a lot of stuff. It was policy, it was data, it was a larger effort. And I would completely agree, not to be dismissive of the pediatric office or the physician office. I tend to think of it not as the pediatrician herself, but as the pediatric office. What is that office doing, as opposed to what is that person doing? And that's, my wife has forced me to talk like that. So.
Right. And I think that goes back to the inside-outside approach, right? Looking, yes, screening for social determinants is important, but At the same time, it's important to also share that data that you gather as a result of your screening and share it with public health organizations like Harris County Public Health, so that we can then take that information and use it to inform some broader policy programmatic initiatives in support of those social issues. And I think that inside approach within the healthcare system has to also include what we're calling structural competency, right? It's understanding, as I mentioned earlier, those structural drivers that influence the distribution of social determinants. So it's important, a lot of healthcare systems are now switching from cultural competency to also include structural competency, understanding what structures are in place and how those structures influence the distribution of social determinants, which is more important and more upstream than just looking at the social determinant itself.
So I was just going to respond. This is on. We clearly don't live in a perfect world, but withholding information that could have a material impact on a patient's visit, think about the process. First, the assessment. If they don't know, doctors are people. They don't know. They're not all omnipotent. So it really does play into initial assessment and then rendering a proper diagnosis. Not knowing some of these things could have a huge impact on the care that's being delivered. Now, is there a risk associated with that? We don't live in a perfect world for sure. But, again, it's a balance, half full, half empty. Do you take that risk and have faith in the physician that's trying to deliver care, that they will weigh those appropriately in the assessment, the diagnosis, and the treatment plan? The other example, Robert gave one earlier, but if there's 3 medications that are the exact best practice protocol for what that diagnosis has observed, and they're very expensive, and they know that they don't have money for food, are they really going to fill those 3 prescriptions? But if he knows that, he or she could say, well, look, if you can only take one, this would be the one that's most effective. So I think you have to, again, there's risk in everything we do, but to withhold that information from a caregiver that will materially impact outcomes, I would advise against.
I think my point is that we don't know the risk, right? So I think in your analysis, you are assuming that the risk is small, that knowing this information would not adversely affect and create sort of reinforced bias and lead to treatment decisions. Let me give you an example. So I teach one class for the medical students at Baylor. And in this class, I actually asked for all the students to take a moment and think about a patient encounter where they may have had bias. And so often in our very busy lives, especially when you're a medical student or when you're training, no one gives you that gift of reflecting and pondering and thinking about, did I treat this person differently because of how they looked? And so every student out of this class of 170 something, they write me basically a note that I go through, and they tell about a time when they realized now, because again, when they did it, they didn't know that's why they were doing it, right? It's only after my class that then they're like, based on the information you've given me, when I reflect upon things that I've done, I recognize that I did things. So examples of that are, I'm glad, smoking, right? So a patient comes in and they smell of smoke, so I figure, why do I bother telling them about smoking cessation? They're not going to do it, right? Or a patient comes in and they're disheveled, and so I think, you know what? They're not going to listen to this advice, so I'm not going to waste my time doing this. I'm just going to do this. So these are not, and all of these things, even though they are well-intentioned, they're the brightest of the bright. I sat on the admissions committee for Baylor for a very long time, so they are good people, good students, good intentions, right? But just because of the fact that whatever life experience they've had, whatever experiences they're having in their training, whatever is being reinforced by the residents and the attendings, they are making quick decisions that influence how they're interacting, what information they're giving, what medication they're recommending, and it's not on purpose. So I think what I'm saying is, I think we need to take a closer look, not saying all or nothing, but I think we just need to engage in this thoughtfully and carefully and thinking about how does this influence bias. That, so I'm not saying that it's a bad thing to look at social determinants of health, or it's a bad thing. It's a great thing for physicians to know if you're food insecure so that they prescribe appropriately. I'm not saying those are bad things. I'm just saying we need to hit the pause button and sort of look at and evaluate how are these in practice influencing patient decisions and how this in practice is influencing bias. And so one solution of that could be, again, hats off to Baylor for taking this initiative, is including this implicit bias training in all of the work that they're doing, right? So Memorial Hermann, while you're giving physicians information, are you also saying, here's cultural sensitivity, implicit bias training to help you make sure that the information I'm giving you is not causing you to reinforce biases, right? So that's one way. So I agree with you. I don't think it's all or nothing. I'm just saying I think we would be amiss. And I think the maternal mortality reports and evidence really shows that we cannot really afford to ignore the role of implicit bias.
I'm just going to do real quick just to differentiate, because there's a lot of things discussed, and it's under the category umbrella of social determinants of health, but in this discussion, we had several different levels of what that engagement means. So we talked about implicit bias, which is that provider and that patient directly, and the treatment you may do, like if they have utility issues, you kind of figure that out. You may prescribe something closer to their home or get something cheaper, a generic drug. But we also talked about policy issues, and also made a step before that, disease management. How can we actually cure that family or help that family on poverty or food insecurity, those sort of things. So as you're engaging social determinants of health, try not to, as best you can, because a lot of times these discussions get lumped together. And if you can differentiate as a provider or somebody who's teaching, there's your interaction with the patient all the way down the spectrum of how your involvement is as trying to treat this as a disease management model or actually getting involved with policy and systems. And just real quick, that's what this page you have right here is for, right here, to kind of help kind of differentiate. But it is because one of those things, like I've had discussions with many of these people, and we're going to go to the next question, which actually relates. Y'all set up really well. But I think a lot of the discussions, you see a lot of people get turned off because they don't know how to get involved with policies and systems and disease management, but they can give you a transportation voucher. So there are things that you can do, and so I just wanted to kind of show that there's a continuum of what that means. But since you already talked about it, let's talk about evidence-based. So there was another forum on Friday, and one of the panelists said this. I kind of stand in the middle of some of these. So there's a lot of talk about evidence-based, and there's a lot of things about doing a lot of pilots. And so I'm kind of putting them together in one bucket. So the panelist said, well, we just do a ton of pilots, and we keep doing a lot of pilots, and they have these outcomes. But we never actually get to doing anything. And they work here and there. So as far as evidence-based and the number of pilots we do, how as a physician, a hospital organization, how should we treat this so it doesn't become a stultifying, a thing that blocks you from progressing, but also then lends itself to still not being a waste of resources and time and is actually showing effectiveness, if you don't mind discussing that. So the role of evidence-based in approaching this subject matter. Whoever, I'm leaving this open to whoever wants to discuss this. Well, I'm looking at you, Dr. Gibby.
I would say that there clearly is growing evidence that work in this space is valuable. There are a couple of challenges to generating appropriate evidence, and one of which is what outcome are you particularly interested in? The work in this space is often complicated, and it's unclear the relationship between what you've done and a particular outcome. And so one of the outcomes that we're particularly interested in as something you can measure and as something that is meaningful for the child and then that child as an adult is early brain development. And if you can identify something measurable that you can influence that is either positive or negative, for an individual person or a child, for our perspective, it's early brain development. For a population, it could be a disease rate. And one of the challenges is in all of this is that many times it takes years or decades for you to have seen an impact. And so taking something from like the tech industry or design thinking where you A/B test things and have meaningful outcomes that you can meaningfully measure and then do an iterative process for the outcome that you're interested in, it's really a fancy way of saying you have to test what you're doing and actually measure data. Just doing it because it feels good is really problematic because there's lots of things that sound good that may not be effective. So generating evidence has to be part of what you do. And the first step is really clearly identifying what are you trying to affect? Because again, for us, early brain development is really critical, and we can measure that, and that can serve as a proxy for some lifelong impacts. And so that's really part of the challenge, is identifying what you're trying to influence and then generating meaningful proxy measures, because you're not going to be able to say, I'm going to do this thing and I will let this population of people have a greater rate of living to 65, because then you're going to take 50 years to identify, did that work? And so you have to have meaningful steps of clear-cut measurement that will, but then the other thing is that you have to have a meaningful time horizon. These factors or forces didn't happen quickly, and so to fix them, it would be foolish to say, this 1 year grant, I will demonstrate food insecurity will go down for this zip code. But that's what grantors often seem to be wanting, and I think it's important for us to be meaningful in the outcomes we identify and meaningful in our time horizon, and that's how I would frame it. I don't know if...
Yeah, so I agree with that, and I would also just say that, you know, many researchers often have intellectual curiosity, or they see an issue and they're trying to discover why. Like, that's why research and academia is appealing, because you know, you have a curiosity, you have an interest, and then you design a research study to answer that question. But not often enough is research designed to answer a question and part of that question is, how do I make this scalable and replicable, right? And so that piece is often left out of these pilots. And so you have one pilot that tests this aspect of that, and then the researchers answer that question. And then often in the paper they say, well, we need more research to figure out these other things, right? And then they get another grant, right? And then they research that component of it. And then they say, we've answered these things, but we still don't quite have it. So we have another question. And so that is how research, that's how the academia functions, right? Is asking questions that then we gain an increase in knowledge, and then we ask more questions. And so I think part of the challenge is, how do we create a research base where part of the driving question is always about, how do we scale this up and how do we replicate this in other places? And I think you'll move the needle much faster when you talk about a broader, larger impact.
Just going down the line. Okay.
No. I was gonna. If you had something to say, I was gonna add to it.
I'll let y'all decide if it was worth saying. So we're very much, we have grants and things like that let us go into fix problems we see. And it's very much metrics-based. We measure everything. We want to make sure there's an outcome for whatever kind of effort we do. But I'll say a few things. One of the things, even though all of our projects, we have a very defined goal, very defined time horizon, we're measuring everything, and we like to be able to publish so we can show this proof of concept. One of the things we love doing is being able to say, even though for instance, with the one issue when we're going after I keep going back to the sidewalk thing, but we're doing a lot of things in that area, but we're able to partner with actually on another grant, we're able to partner with community organizations who've never worked with, something like Memorial Hermann. And so the partnership requires a greater amount of rigor than they've ever been used to doing. And so it scales up their competencies that enables them to, one, leverage those new capabilities on another problem, but also it empowers them to be able to fix other issues that they never would have had the resources to do had they not worked with us before. So maybe we were going in for one thing, but all of these other impacts happen as a result. So that's good. And then another great thing is, we start on this one project in this one area to be able to do this one piece of work, but we have this outcome. And so now we can now go to Aetna and talk to you about the fact that we've learned how to now bring down a certain thing. We can now, I'm in the community benefits piece of our system. Memorial Hermann is a large system. So we can now go to our leadership and say, hey, we did this project and it showed this amazing ROI. Oh, great, you're now funded to scale it. Whereas before we were using a grant to start it, now we're able to move it across our system. That's what we've done with some of our food insecurity work. And so we might not have, when we started the food insecurity work, we were around the nation looking at what people did, called different people to get a better idea about how they're screening patients in their ER. But even it wasn't proven out, and we didn't have every single piece of it structured. Just starting it and then going through the iterative process of figuring it out has been very useful for us.
So at Harris County Public Health, a bulk of our programs are based on evidence and practice-based interventions, but there are a number of innovative projects that kind of push the limits a little bit, right? We think about these cutting edge technologies that kind of are in a different time mode than our public health academia research. And so we want to take advantage of those technologies, right? We want to utilize drones, for instance, when looking at hazardous environments or any environmental impact within a community. And so we're utilizing technology and thinking about how we can innovatively approach some of our public health issues and create solutions that are outside of typical evidence and practice-based solutions.
So just kind of taking from what y'all said, so I think many people in this room are bleeding heart caring people. So you see people who are suffering from poverty or from hunger or all these issues, or people like I said, Deer Park and those types of issues, and you just want to do something now, or you want to do something to affect that change, because the longer you wait, there are people who are suffering, and that's the issue. And change for population health takes a long time. So a lot of you referenced the grants. So is there any advice for people who may be listening, who may be from a foundation, as to how you would advise them to structure some of these grants that may make this maybe more meaningful use of your time, and maybe get to some of those outcomes that you may be looking for, or the results, whether negative or positive, a little bit quicker, not quicker, but maybe more effectively. How would you advise the philanthropic organizations on their grant making, if at all, or if it maybe define how it is? Anybody?
So I think innovation requires the opportunity to fail, right? When you look at tech innovations, sometimes ideas don't work and they start from scratch and, create a different idea that's slightly nuanced. So I think a lot of grant opportunities don't offer the freedom to essentially learn from errors and kind of start over and continue to be innovative and not necessarily beholden to these practices that take a very long time to see outcomes. So that's one idea.
Yes, you have a question?
Hi. So post Harvey, et cetera, we had a lot of efforts by Baker Ripley, and now we have Episcopal Health. So are there anything coming from those two organizations that are actually impacting directly into the community that you can advise us on? Thank you.
Yeah, so the project I'm working on, Community-Centered Health Home, is powered by Episcopal. We've just been able to do a lot of good things. They've given us the ability to figure out what works and about partnering and working together on affected communities. So I can say about that.
I
Baker
can,
Ripley.
I can add a couple of things. So this community-centered health homes, that's one example, which is, if you're familiar with the patient-centered medical home, which is trying to coordinate the clinical aspects of it, but this is also now then taking it to the community to see like, what can the healthcare entity, how can they better understand what's going on around them and incorporate that into their care and maybe align certain things. Another one, several of the foundations, Episcopal Health, Houston Endowment, other ones, they're actually, this kind of actually plays a little bit of some of the issues that I'm kind of referring to. We have a couple of pilots of similar programs going on, which I would kind of prefer some of these be kind of combined. But there are some really good efforts going on around in terms of how can we better have a continuum of care between physical, mental, and social issues. And not lose that patient as they're traveling between different institutions and make sure that patient is being tracked the whole time. So there's some really good pilots going on with that. And I think there's some, they've been funding initiatives related to, for the first 3 years, some of the traumatic issues going on with things. So there's a lot of initiatives that are going on. So I do give them a lot of credit at that. I mean, some of my, I'll be honest, as a moderator, but as a panelist now too, is I wish some of these things were a little bit longer at the front end. I think the planning and the implementation, I wish it was almost automatic for some of these people, because you see a lot of things, the planning goes and the funding doesn't come thereafter. So that would be one of my particular things I would advise, to kind of make that almost just hand in hand. Somebody had a question?
Is there data out there available to the general public about what are the health challenges, what are the social determinants of health for certain parts of Houston, neighborhoods, zip codes, or whatever? Is there data out there that we could access that anybody knows of?
Well, yes. Well, you have the Health of Houston survey, right? Which I don't know, is that broken down by neighborhood? So someone in the audience can answer your question.
So the Health of Houston survey will be available at healthofhouston.org in about 3 weeks. And the data are accessible and free to anybody who has an internet connection. And you'll be able to look at 38 areas within Harris County, divided up into aggregations of census tracts. And we've got about 65 health indicators that will actually be on a mapping platform, and you can move across the areas to see what the zip codes are and where the neighborhoods are and what's happening by indicator. And then you can compare it back to 2010 when we last did the Health of Houston survey. So we're trying to do that.
And then the urban data platform at the Kinder Institute at Rice University, we are uploading the Third Ward data, and then we replicated that work in Sunnyside as well. And then I think there's a couple of other communities that have a more comprehensive approach or data around all of this, around many of the social determinants of health that are not included in the Health of Houston. So you could look at sort of both of those and how they relate to one another.
For kids, you can use Growing Up in Houston, Children at Risk, every other year puts out a large data compendium of different social issues and factors affecting kids' lives. It's called Growing Up in Houston. It's free, it's online. And I often go to the CDC has a data set called 50 cities, and Houston is, because it's one of the 50. You can look at data by zip code for tons of different factors, and this is sort of one of the data warehouses that is available. And then if you really want to get nerdy, you can go to the American Community Survey, and you can go to the Census Bureau, and you can look at Greater Houston in the Census Bureau, and you can get how many people per room per household, and you can get that granular. If you do, I would caution against it, because you have probably greater problems. So.
And just a couple other extra maps. If you go online, you look up the UT Houston food map. That does give you at least a definitional spray of where food insecurity is. And there's recently, I think there was a map. I forgot which entity at the University of Texas system created a life expectancy map across the country using, I think, CDC data. So those are some things you can look at. We only have a few minutes, but I'm going to try to give them a whopper of a question that they can't answer in 5 minutes. So, all right, so the last question for them, and thank you all so much for all this. This has been great. Okay, so thus far we've been talking about there's systems change and there's also personal ability, accountability. So we talk about food insecurity, all these different types of things, and so there's system change, which we can bring in maybe a grocery store into a neighborhood, but what's to say those people are not just going to bypass the healthy foods that are there and just still go to the unhealthy section still. So that's an example. So as we're working on systems, what's the balance between working on systems policy initiatives to actually affect change, but also in the personal behavior issues, and because there is a level of personal accountability that has to be accounted for. So just within the last few minutes, if you don't mind.
So I think that partnering with a community helps to address that, kind of in a 1-2 punch, right? So if you engage the community around issues, like, so for instance, let's just use health behaviors, like you just mentioned, eating healthy, right? So on one end, I could say, well, I'm an expert in this area and I have data that you people in this neighborhood don't eat well and you're obese and you have high rates of diabetes. And so I'd like to change that. And so what I'm gonna do is talk to Scott at HEB, and I'm gonna, advocate with city council, and I'm gonna talk to the mayor's office, and I'm gonna say, you know what, we need a HEB in this neighborhood because folks aren't eating well. And then just say with all your magical powers, HEB does indeed build, a grocery store in that community. Well, you leveraged all of sort of the policy and resources to make this happen, but now you find out, oh, nobody actually goes to the HEB. Oh, there wasn't a bus line actually on the way to the HEB, and so people can't actually get there. Oh, there's this other issue, right? And so you've created this thing in a vacuum. But if you partner with community around the issue, so you can have this data and present it back to the community and say, how does this resonate with you? What are reasons that you think you're having, these are your challenges, right? As opposed to me thinking, oh, the reason why you're having this problem is because you didn't have a grocery store. You're in a food desert. And I know this because I'm an expert. But really, the community is an expert about their lives and their challenges and the things that they need. And so if there's a partnership there, right, to where you're asking the community, why aren't you eating healthy? You may find that the answers are not something that you yourself, the expert, would have come up with. Right, and so I think we really bridge that by these partnerships with the community.
That's great. That's great. And anyone want to add? You got a minute or two to add to that.
You can't improve upon that.
You cannot. We actually have a few. Oh, great. Thank you.
If there's a left-right dimension to this.
Okay.
Because when you look at the early history of social determinants, the focus included upstream political regimes. And it happened in the UK when these were implemented in the 70s, a number of these initiatives. It was under a Labour government. And when the Conservative government came in, they shut them down and they reprioritized. And when you talk about collective activism for social change, you're on one side of the political spectrum. And I wonder to the extent to which there's kind of an ideological eligibility with respect to thinking that social determinants are important regardless of what the evidence says, and being willing to do something about it in communities. I mean, we're in a blue zone here in a red state, but does it require everyone to be blue?
That's a good question. There you go. That's the layup. Go ahead.
SWAT. So I would always look at this as Michael Marmot had said, my hero. He says you have to talk of social determinants of health with both the head and the heart. And the head is what's the data show, what's the impact, what's the cost savings. The heart is the moral imperative, and that the idea is it's the right thing to do. And he says ultimately what is successful is it's the right thing to do. Now I'm not sure that's true because I don't think he's ever been to Texas, but I think that those are the two languages that need to be learned. There are ways to frame this that I think can answer the most strict conservative as well as the most strict, most open liberal. If you look at the larger social costs of not attending to those, it really, you can talk about the economics of the impact of not doing this, and that can be a language that you will have to learn if you want to change policy. You have to talk about that early brain development is directly related to all claims insurance for a population, that early brain development is related to criminal justice costs, and that there's clear, the Gini coefficient, there's clear inequality, there's clear relationships. But then you have to also be able to argue the moral imperative, that there is suffering in the world, and we have to, that is our calling to decrease suffering in this world. And so learning both of those languages, if you learn just one, you will have a very selective audience. You have to learn both.
And I think engaging the community is important, not only so that they drive the solutions, but so that they are democratizing health in a sense, right? If they go out and vote, so to speak, we won't have as many barriers in terms of policy changes. Voting makes a world of a difference, right? And so engaging the community also includes building power within the community so that residents can exercise their right to vote and make sure that these issues are on the table for their elected officials.
Right. And with that, we will end it. I just want to say this was an awesome class. I think you should go back and watch this video again, because there was a lot of things discussed. I mean, there were a lot of issues that were brought up. There were a lot of issues discussed, and there's some nuances that hopefully you caught. But I would actually go back, because these are a lot of discussions and issues and solutions that have been discussed for a long time. So thank you, Elaine. Please give them a round of applause. And give me a round of applause. No, I'm just kidding.